Hello, I'm Dr. Nandita Palshetkar, the President-elect FOXY 2019, and I'm happy to be part of this digital course on PCOS run by FOXY and Artist. As we all know, the Rotterdam Consensus of 2003, where ESHRE and ASRM proposed a new criteria for the diagnosis of PCOS. They said at least 2 of the 3 features are required. One is anovulation, second is hyperandrogenism, and third is a PCOS on the sonography. Any of these 2 criteria suffice to say that the patient is polycystic ovary. But recently, there was a paper in August 2017 which actually told us the value of AMH. And I think times have definitely changed since 2003. A lot of new factors have come in, and AMH is one of the tests that we really use, one of the biomarkers that we really use to identify PCOS. So AMH may be replacing the TVS. Measurement of testosterone alone is insufficient for the diagnosis of hyperandrogenemia. SHBG and free testosterone levels should be measured, and the glycosylated hemoglobin may be very informative about insulin resistance. There's a lot of problems associated with polycystic ovary, but recent studies have also shown that it causes endometrial inflammatory changes also. So it's very important to treat the disease before getting the woman pregnant. The correlation between serum AMH and HOMA-IR among PCOS phenotypes. I think this is very, very important. This was a study by Viveco et al. In 2018 January, and it says there was a positive correlation between serum AMH and HOMA-IR levels. So the serum AMH levels correlate with with insulin resistance. Let's call it insulin resistance. When the phenotype 1 was present, that means the patient had anovulation, hyperandrogenism, and PCOS on ovary. These are the cases where the AMH and the insulin resistance really correlate in the maximum. Today my topic is PCOS and infertility. We all know that PCOS affects infertility by causing anovulation. So what are the principles of ovulation induction? I think this is one of the mainstay of the treatment of PCOS, ovulation induction. So what do we want to do? We want to achieve pregnancy in the shortest time, avoid OHSS, and avoid multiple pregnancy as well. So the drugs of choice are clomiphene and letrozole. And it has been shown, there's been a lot of controversy about metformin, adding metformin to these drugs. So clomiphene citrate is usually started in the dose of 50 to 150 milligrams per day for 5 days. And usual practical way of starting it is 100 milligrams per day. It is given for 5 days, and then the ovulation induction is monitored. But studies have shown that if you add metformin to this protocol, definitely it improves all the parameters, like improves the reproductive endocrine and lipid metabolism of obese PCOS patients, decreases the volume of the left and the right ovaries, and increases the menstrual recovery, ovulation, and the pregnancy rates. Of course, there are certain patients we all face that, they're just not responding to clomiphene citrate. And this study was a beautiful, way of telling us which are the patients where we would have failure of clomiphene citrate. And I think today AMH is so popular, and it has been shown that AMH level of more than 8.58 nanograms per ml would indicate clomiphene resistance. So as we know, the higher the AMH levels, definitely there is a resistance in ovulation in these patients. And today there are 2 drugs which are available. Clomiphene, which we've been using for a long period, and letrozole, which has been reintroduced into practice right now. And if you can see in this chart the differences between the 2 drugs. The half-life is longer with clomiphene citrate than with letrozole. The anti-estrogenic effects are seen in some patients with clomiphene citrate, like thin endometrium and an altered cervical mucus, whereas with letrozole, you get a good endometrium and a favorable cervical mucus. You don't see this anti-androgenic effect. The uterine blood flow is decreased with clomiphene citrate, increased with letrozole. Miscarriages rate probably high and less incidence in letrozole. The OHSS risk is higher in clomiphene citrate because you land up producing more eggs, and it is lower as compared in letrozole, and therefore that translates equally into multiple pregnancy rate is higher in clomiphene because of the number of eggs and lower in letrozole. Eleven RCTs were included in this meta-analysis with 2,255 patients. The meta-analysis compared letrozole and clomiphene followed by time intercourse, and you can see the ovulation rate, the pregnancy rate and the live birth rate significantly increased in letrozole stimulation as compared to clomiphene. However, the letrozole and clomiphene did not differ significantly in terms of multiple pregnancy and abortion rates. Furthermore, letrozole for ovulation induction significantly improved the pregnancy rates after IUI. The conclusion of this meta-analysis was that letrozole is superior to clomiphene citrate for ovulation induction in patients with PCOS. Another worry that we have is, does letrozole cause increased congenital malformations? And we have multiple studies, the Tulandi et al. In 2006, Sharma et al., which is an Indian study in 2014, and a meta-analysis which was conducted by Tatsumi et al. In 2017, which shows that there is no increase in risk of major congenital anomalies or adverse pregnancy or neonatal outcomes. I think this gives a sense of relief to all of us when we are using letrozole as the first choice of drug in PCOS. The next part of ovulation induction is the usage of gonadotropins. So if we have a patient who has a failure of clomiphene citrate or has not conceived after clomiphene or letrozole stimulation, I think the next protocol that we go to is gonadotropin stimulation. And in gonadotropin stimulation, low-dose step-up is the regime that we use. Here we start gonadotropin on day 2 at 75 international units, and every week you increase the dose. You have to be very careful with it, and if you do this low dose step up, definitely you will get good results and a monofollicular ovulation. So in PCOS patients, the second protocol of choice is low dose gonadotropin. But in our Indian scenario, what I like to do is this protocol, the clomiphene citrate plus the FSH protocol. So we start clomiphene citrate on day 2 to day 6. You can also replace it by letrozole, and day 7 you start the gonadotropin 75 international units daily. Remember to monitor the cycle and then give the trigger. What this protocol does, it reduces the amount of gonadotropin usage, so therefore the cost of the cycle, without much affecting the pregnancy rate. So this is a good protocol, and I use it a lot in all my patients. So in my patients, what I do is 2 cycles of CC or letrozole. If they don't conceive, then I go to CC plus letrozole, or CC plus gonadotropins, or letrozole plus gonadotropins. Myonostal is another drug which is used in PCOS. It ameliorates the insulin resistance. It acts in many different ways, like increasing the insulin sensitivity, reducing the insulin resistance, improving the glucose utilization, free and serum testosterone levels are reduced, provides good quality oocytes, restores menstruation and normal ovulation, and improves pregnancy rate. This was published by Pundir et al. In the British Journal of OBGYN in 2017. It's a very good meta-analysis of comparing inositol metformin in PCOS PCOS patients. It consists of 10 RCTs, and it has been shown that inositol is very good. It regulates menstrual cycle, improves ovulation, and induces metabolic changes in PCOS. However, the evidence is lacking for pregnancy, miscarriage, or live birth. So further well-designed multicentric trials are needed to address this issue. And there are a lot of studies coming up now saying that inositol is as good as metformin. And in my practice, I have started using both of them. If you compare metformin to weight-reducing agents like orlistat, definitely metformin comes out superior in regularizing menstruation and improving the ovulation rate. But obese or anovulatory patients with a low basal LH are the ones who really give a good response to medical therapy. The important part of ovulation induction is ovulation monitoring and the trigger, because remember, if you just give clomiphene citrate without monitoring, there is very high chance of this patient landing up with OHSS, and this is a dreaded complication which we do not want. So monitoring should be done. On day 2 of the cycle, an ultrasound is done to do the antral follicle count, to check for adnexal pathology, and then the dose is decided. Again, the patient comes to you on day 8, and then depending on the size of the follicle, the gonadotropins are added. So when you add the gonadotropins, you would increase the dose only after 7 days. So day 2, day 8, day 10, and usually the trigger is given on day 12. Ovulation trigger is done when the leading follicle is usually 18 to 19 mm in a natural cycle. If you've used clomiphene alone, then it's better to have a 20-22 size follicle. If it's a combination of clomiphene and gonadotropin, anything between 19 to 20 is fine. Gonadotropins can be triggered early. If the follicle size is anywhere between 15 to 19 mm, you can actually you can trigger ovulation. A point of note and importance is the agonist trigger. Agonist trigger works wonders in PCOS. It prevents OHSS, and the dose that is used is subcutaneous injection of 0.2 milligrams of triptorelin or leuprolide acetate 2 milligrams. And usually the decision to use this trigger is with excessive follicular response, because remember, when you use this trigger, the luteal phase gets affected, and you really have to use a very high supportive luteal support if you use this trigger. The GnRH is administered at least 8 hours following the last GnRH antagonist injection. And generally, the oocyte retrieval is performed 34 to 36 hours following GnRH analog administration. There are a lot of papers now coming saying that if you give HCG plus GnRH analog, the quality of the eggs is good. But remember one thing, you should always use only GnRH trigger when you're using it to trigger ovulation in PCOS patients and in oocyte donors, because the safety of this trigger is well established and well researched. Another protocol that is really useful in PCOS, especially those resistant PCOS who don't respond, is the chronic low-dose step-up protocol. In this protocol, you start with maybe 50 international units of FSH for 14 days. You don't step up the protocol unless the follicle is not growing, and that too only after 14 days. You increase the protocol by say half an ampule or even by 50, so you increase the dosage to 100, and you continue it for 7 days. Usually in the chronic low dose step up protocol, the follicle grows anywhere between the 20th to the 30th day, and it's a good protocol, gives equally good pregnancy rates. Only problem is that you have to counsel the patients, because all of my patients turn around and say, but doc, I'm going to get my periods now and you're doing an IUI. So you need to explain to her that it is the follicle which has taken long to grow and she need not worry about anything else. The OHSS prevention is very important in PCOS patients, and the recent implication of 4 new modalities has really contributed to OHSS free clinic. The GnRH antagonist protocol, the GnRH agonist triggering of ovulation, blastocyst transfer, and embryo and oocyte vitrification. These 4 processes let you get a OHSS pre-clin. The last arm of the treatment is IVF ICSI. I think in PCOS patients, you have to keep this at the back of your mind that if ovulation induction fails, IUI fails, you must go for IVF. IVF ICSI treatment in PCOS is recommended either as the third line of treatment or in the presence of infertility factors such as tubal damage, severe endometriosis, or male factor infertility. Women with PCOS undergoing IVF treatment achieve similar pregnancy rates and live birth rates as compared to those of the non-PCOS patients. However, women with PCOS experience a higher risk of ovarian hyperstimulation syndrome. Therefore, the GnRH antagonist protocol is preferred with the GnRH agonist as a trigger in these patients. So, in vitro maturation is another technique which is one of the treatment protocols for PCOS patients. Those PCOS patients who develop really a lot of follicles with even the lowest dose of stimulation are the patients who require IVM. In IVM, what we do is FSH priming on day 3, 4 and 5 only. HCG is given on day 8 when the follicles are 12 mm. Retrieval, filtration and identification of the oocytes. Maturation for 24 to 48 hours, and once we get M2 injection eggs, we do ICSI and embryo transfer. Though the clinical pregnancy rate is lower, 20 to 40%, but in those patients who have poor response or those who develop a lot of follicles, this treatment would be ideal. So the flow chart, I would just like to run you through what I've talked about. So you can start with clomiphene or letrozole. Clomiphene 100 milligrams per day and letrozole 5 milligrams per day till ovulation. That means 2 or 3 cycles. If there's no ovulation, you add metformin to it, 1500 to 200 milligrams per day plus clomiphene citrate or letrozole. If still there's no ovulation, then you can go to ovarian drilling or gonadotropin. And gonadotropins, if there's no pregnancy, then we go to IVF. In the other arm, if you've had ovulatory cycles, you go to IUI. If IUI does not work, then you go to gonadotropins with IUI, and if that does not work, then it's IVF. So if you look at a patient of PCOS, this is how I would treat her. 2 cycles of ovulation induction only with clomiphene citrate or letrozole. If that doesn't work, I'd start IUI. In IUI, we take CC plus gonadotropins for IUI, maybe 2 to 3 cycles. If that doesn't work, I would straight away go for IVF. So it's a very simple chart which you must remember. Only if the patient is young, yes, you can try 3 to 6 cycles of IUI. But generally what happens, unless you've counseled the patient will get exhausted, fed up, tired and switch doctors. So that's why it's better to do 3 cycles of IUI with gonadotropins and oral ovulogens. If that doesn't work out, we should go for IVF. And the Thessaloniki paper which was brought out did mention that the first line of treatment is lifestyle modification, second is ovulation inducing drugs, and the third line is IVF in some patients. So we must remember to be able to offer this treatment to the patients because the success rates are very, very good. Surgical treatment of PCOS, ever since we were in medical school, the first endoscopic surgery that we learned was drilling. And today we have realized the folly of that drilling. Drilling does cause a reduction in AMH. So I would advise all clinicians to do an AMH before doing a diagnostic laparoscopy. Because if the AMH is low or borderline, drilling will only damage that ovary. And in fact, this latest meta-analysis in 2017 by Amir et al., which included 6 studies and 442 patients, showed a significant decline in AMH. So we really need to be very aware when we are doing drilling. Another surgery which is really now become very popular for obese PCOS patients is bariatric surgery. There are multiple surgeries which are available, but usually these surgeries are indicated when the BMI is more than 40 kilograms per meter square or it is more than 30 kilograms per meter square with coexisting medical problems like diabetes or blood pressure. Usually the patient loses over 20 to 40 kilos over 2 years. It can improve menstrual irregularity and fertility in obese females. It treats associated metabolic disorders. You can maintain the weight loss for 10 years. But pregnancy is not recommended during the first year of surgery. So I think this information has to be communicated to the patient. And even if the patient conceives after bariatric surgery, a lot of attention has to be given to the nutrition so that the baby does not face the lack of nutrition in utero. Long-term effects of PCOS are very well known. Visceral fat, which is the root cause of the disease, it causes dyslipidemia, insulin resistance, type 2 diabetes, inflammation, thrombosis, and hypertension. And as gynecologists, we see these patients when they are young, and they should be warned about the long-term effects of PCOS and how lifestyle and behavioral modifications can actually prevent these disorders. Another problem which I've seen is psychological problems. A lot of PCOS girls are in depression, and this needs to be picked up, evaluated, and treated definitely. Another new thing in the treatment of PCOS is adenopectin. It has been shown that adenopectin plays a role in PCOS, and this treatment may be a novel therapeutic strategy for combating PCOS. And there are lots of new things which are coming about now. So to conclude, the main therapeutic approach is lifestyle modification, and metformin is the primary insulin sensitizing drug to be used as an adjuvant therapy to lifestyle modification in patients with insulin resistance, impaired glucose tolerance, as well as those referred to for infertility treatment. And to summarize the ovulation induction, please do the EMH of the patient because it will guide you regarding the dosages. Letrozole, clomiphene citrate, metformin, inositol. These are your first drugs of choice. If they don't work, then you start with clomiphene or letrozole plus gonadotropins. And if that doesn't work, low-dose gonadotropin protocol, antagonist protocol with agonist trigger. These are the protocols that should be used in a patient of PCOS with infertility. A lot has changed in the understanding and management of PCOS, yet we have a long way to go. Thank you.